Hello guys, good evening everyone. So last time we started with chronic heart failure and we'll try to continue where we left off. Yes. Good evening, Chatra. Good evening. So let's wait for 5 more minutes till some more students join in. And till then, what we can do is maybe we can revise a bit. We've done the pathogenesis and we've stopped somewhere near the cardiac cycle. So I told you the phases in cardiac cycle, but maybe let's revise it since we have some time. Yes. See, I will tell you some basic concepts about pressures that are present in the heart. I guess you guys are very accustomed to pressures in life. Yes, medical students have a lot of pressures in life. Same way, there are a lot of pressures in heart. That's how the valve opening and closing works based on the pressure. I've drawn one side of the heart. Let's imagine this is left atrium and this is left ventricle. Now, imagining that both of the valves are closed. Between left atrium and ventricle, which valve do you have? Comment it. Between the left atrium and ventricle, what is the valve that you have? It's already written here. It is atrioventricular valve and the name is mitral. And which valve do you have between LV and aorta? It is an aortic valve. Yes. Now imagine all the valves are closed. If you want to open If you want to open the mitral valve, how can you open it or how does the heart open it? See, imagine if the pressure in the left atrium increases more than the pressure of the left ventricle. It will push the valve to be opened. Understood? So, if the pressure in one chamber exceeds the pressure in the other chamber, that's when the valves are open. Now, imagine the other way is true. If the pressure in the left ventricle crosses the pressure in the left atrium, that is when this valve is closed. That is what we studied in cardiac cycle previously, if you remember. These are the phases that I told you. Let's start from isovolumic relaxation. We can start from anywhere. Last time we started from rapid filling. So this time I'm starting from isovolumic relaxation. Isovolumic relaxation meaning this is cycle of ventricle. So ventricle is relaxing. What is the meaning of isovolumic? The volume remains the same. If the volume in the ventricle has to remain the same, the blood should not come in or go out. So both of the valves are closed. Now let's imagine there is isovolumic relaxation. Now, during isovolumic relaxation, the left ventricle starts relaxing. When it is relaxing, the pressures in the left ventricle will fall. When the left ventricular pressures fall below the left atrial pressures, that is when this mitral valve will open. That is why mitral valve is opening after the isovolumic relaxation. Did you understand how the valves open and close? If you did, leave me a comment. If you don't, let me know. I'll repeat it again for you. So somebody is asking me what is preload and what is afterload. See, as I've told you last time, preload is nothing but the load that the heart is getting. Where do you get the load into the heart? You get it from the right atrium from the vena cava. So superior vena cava and inferior vena cava will give blood into the heart. Yes, through right atrium. So that is what is preload. Basically, the blood that is in the atrium, in the ventricle, before the systole, that is what is known as preload. It is equal to the end diastolic volume. So whatever volume we have before the systole at the end of diastole is what is known as preload. So basically preload is equal to venous return. So if venous return is increased, preload increases. Now, what is afterload? Afterload, the meaning of afterload is the resistance that LV must overcome to circulate the blood. That is what is known as afterload. So what is the resistance to LV? It is the resistance coming from the aorta. So what is the resistance that is present in aorta and the blood vessels known as? It is also known as systemic vascular resistance or total peripheral resistance. Yes, that is preload and afterload. I hope you guys understood. Now coming to this concept, so it makes it very easy. If the pressure in the left atrium crosses the pressure in left ventricle, this valve will open. Next, if pressure in left ventricle crosses the LA pressure, AV valve will close. Same way, if pressure in left ventricle crosses the pressure of aorta, aortic valve will open. If pressure in aorta crosses the pressure in left ventricle, that is when aortic valve will close. Yes, this we've already done it in the cardiac cycle. I am repeating it to you with respect to pressures. Yes, so we will start the today's lecture and we have to start it with symptomatology today. So symptoms and signs that you see. Before starting the lecture, few simple questions. What is the most common cause of right heart failure? If you know it, do comment it. The second question, what is the most common cause of isolated right heart failure? And the third question is, heart failure cells are seen in which organ? Is it in heart, liver, lungs, or spleen? If you guys don't know it, no worries. We will see this and you can be able to understand. Good, Chetra. Yes, left heart failure is the most common cause of right heart failure. We will see how that is. Good, good. Now, before starting the symptomatology, we need to understand the circulation of the heart. Yes, how the heart is circulating blood to all parts of our body. Let's start anywhere in the diagram. Yes, we'll start from here. This is left atrium. This is left ventricle. This is right atrium. And this one is right ventricle. Yes. So as I've drawn right side with blue color, so you're getting deoxygenated blood into the right sided chambers, oxygenated blood into the left sided chambers. It is fairly simple. First, let's start from here itself. So you're getting deoxygenated blood into right atrium through vena cava. What are those? Superior vena cava and inferior vena cava. So deoxygenated blood is coming into the right ventricle and it is pumped into the lungs through pulmonary artery. Yes, pulmonary artery is taking the deoxygenated blood from the right ventricle and it is pumping to the lungs. That is what is happening. See, usually arteries carry oxygenated blood. This is one such artery in the body where it is carrying the deoxygenated blood. Did you get it? So the artery which carries deoxygenated blood is pulmonary artery. So it is taking the deoxygenated blood into the lungs. You know the lungs are made up of alveoli. Yes, we are breathing air in. We are taking oxygen, carbon dioxide, nitrogen, everything Once the oxygen goes into the alveoli, imagine this is an alveoli and there is a pulmonary capillary. So we are breathing the oxygen in. Yes, this oxygen is taken up by pulmonary capillary and this releases the carbon dioxide outside into the alveoli and we are exhaling the carbon dioxide outside. So basically oxygenation happens in lungs. Yes, so this deoxygenated blood is oxygenated in the lungs and we are getting the oxygenated blood and this oxygenated blood is taken up by veins in the lungs. They are known as pulmonary veins. Usually veins carry which blood? Usually veins carry deoxygenated blood. But the veins in the body which carry oxygenated blood are pulmonary veins. So it is carrying the oxygenated blood into left atrium. From left atrium into left ventricle, you're getting the oxygenated blood. Now, left ventricle will pump this oxygenated blood to all parts of our body. Yes, this is happening during systole. So as I've told, systole is contraction, diastole is relaxation. So during the systole, the left ventricle is pumping the oxygenated blood to all parts of our body. So oxygenated blood is going into aorta. Aorta is giving out so many branches. Aorta gives out arteries, arterioles, and capillaries. Capillaries will take the oxygenated blood to all the cells of our body. Let's imagine this is one cell in our body. Now, tell me one thing. Why do we need oxygen? Think about it and let me know in the comments. Why do you need oxygen? Why do we need oxygen in our body? The oxygen is required for functioning of all our cells, that much we know. And one of the most important function of oxygen is it is helpful in something known as aerobic respiration, that is aerobic glycolysis. Good Shabuddin, to oxidize the biomolecules and get energy. Yes. So basically, we are using oxygen for metabolism to release energy. Yes, to release ATP. What is aerobic glycolysis? It is conversion of glucose into what? It is conversion of glucose into pyruvate. This is what is known as glycolysis. If it happens in presence of oxygen, that is aerobic glycolysis. This will release 7 ATP. Yes, then pyruvate will go into a link reaction and it will release what? Do you guys remember? It will release acetyl CoA. Yes, from one molecule of glucose, we are getting two pyruvates. Glucose is a 6-carbon molecule. Pyruvate is a 3-carbon molecule. So 2 pyruvates, 6 carbons. We are not losing any carbons in the glycolysis. In link reaction, we are getting acetyl CoA. From one pyruvate, you will get 2.5 ATP. There are 2 pyruvates, so you're getting 5 ATP. So acetyl CoA will go into Krebs cycle. From one molecule of acetyl CoA, you will get 10 ATP. So 2 pyruvates are there, 2 acetyl CoAs are released. So 2 acetyl CoAs, 20 ATP. 10 into 2 is equal to 20 ATP. So 20 plus 5 plus 7, 32 ATP. So this was the question that has been asked previously. Energetics of glucose molecule during the aerobic respiration. If oxygen is present, glucose is utilized to give 32 ATP from one molecule of glucose. That is in presence of oxygen and mitochondria. Now imagine if the oxygen is absent. What will happen? It cannot undergo aerobic glycolysis. It will undergo something known as anaerobic glycolysis. And from one molecule of glucose, you will get only 2 ATP in anaerobic glycolysis. Did you understand? So you're getting 32 ATP in oxidation, I mean, in presence of oxygen. In the absence of oxygen, you're getting only 2 ATP. Why? In anaerobic glycolysis, glucose is converted to pyruvate, but this pyruvate is again converted into lactate. This causes lactic acidosis in the body. That is why in shock and all, we check for lactate levels to understand if the body is having enough level of oxygen or not. So from this, you understood oxygen is really important. We get oxygen from the heart, from the left ventricle through the aorta during the systole. So this is the normal functioning of the heart. Now, if there is a problem in any of this, we will see what will happen. First, we will see something known as, first we will start with LV. Because systole is happening from LV, we will start there. Imagine that there is an LV failure. Imagine that there is an LV failure. So how will you get LV failure? You guys know what is heart attack? It is equal to myocardial infarction. It will lead to something known as myocardial infarction. If there is myocardial or heart attack, yes, there is death of tissue that will cause failure of tissue. Imagine if there is LAD block, it is causing infraction in left ventricle, it will cause left ventricular failure. Left ventricular failure can be of two types. It is systolic failure, that means difficulty to pump, and also diastolic failure, that means difficulty to fill. First, we will talk about difficulty to pump, that is systolic failure. That is systolic failure. Now, what will happen in systolic failure? What is the meaning of systolic failure? The systole is not happening. That means left ventricle is not pumping the blood properly into the aorta. So if the blood is not being pumped into the aorta, what will happen in the body? So as I've told you, oxygen is supplied to all parts of our body from aorta. Now, if there is no pumping, there is no oxygenated blood into the aorta, so you're not getting oxygenated blood into the tissues. Now, which tissues, what are more important? Now, for all of our energy needs, we need oxygen. If oxygen is reduced, there is no energy and it causes tiredness or fatigue. Tiredness or fatigue. So if there is systolic failure, first thing it will cause tiredness or fatigue. Now, heart supplies blood to the brain. Yes, if there is decreased blood supply to the brain, it will cause altered mentation. The same way, if the blood supply to the kidney is decreased, the blood going to kidney decreases, GFR decreases, and urine output will reduce. That is causing oliguria. Same way, if the blood is not being pumped, the cardiac output decreases and also the blood pressure is decreased. If blood pressure is decreased, the blood going into the peripheries will decrease and it will cause cool extremities, and peripheries might even look pale. That is what is known as pallor. Yes, so these are the symptoms that you can see with LV failure. Yes, now what else can you see? You can see some signs. Which signs are those? Which signs are those? You can see something known as S3. Yes, we have talked about heart sounds. I told S1, systole, S2, diastole, and S1. S3 will happen during which phase? I already told you in the last lecture, S3 is happening during rapid filling phase in the diastole. Now, why is S3 happening in systolic failure? In systolic failure, the blood is not being pumped outside, so it is pooling in the left ventricle. So and systolic volume increases. If there is lot of blood in the left ventricle during diastole, the blood has to come again from the left atrium. So this blood will come into this blood, and what will happen? It will create a sound, that is what is known as S3. S3 is therefore a diastolic heart sound. It is also known as S3 ventricular gallop or S3 gallop. Yes, so this is what you can see in LV failure. And one most important thing is you can see something known as pulsus alternans. You can see pulsus alternans. What is the meaning of pulsus alternans? It is the high and low volume pulse that is alternating. So when you're checking for your pulse, first you will have good volume, good amplitude pulse. Next, you will be having low volume pulse in the next beat. That is what alternance means. Alternating high and low volume pulse is what is known as pulses alternance. So these are the LV failure symptoms, and these are also known as what? Forward symptoms. Why forward symptoms? Because the blood is not going forward. That is why these are known as forward symptoms. So whenever there is a failure of LV, if it is a systolic failure, it will cause forward symptoms. What are the forward symptoms? It is fatigue, altered mentation, oliguria, pallor, cool extremities, and S3 and pulses alternance. Next, most important physiology point coming here. Now, I told you there is systolic failure of LV. Now, what will happen when there is a systolic failure of LV? This is very important statement. Try to remember this. Any chamber that doesn't contract properly will not relax properly, or it will not relax adequately. So try to understand this. If a chamber is not contracting properly, it will also not relax adequately. Yes. So if there is a systolic failure, that means if it is not contracting properly, it is not able to relax properly also. So systolic failure is causing diastolic failure. So now there is diastolic failure of LV. What will happen when there is diastolic failure of LV? The blood is not filling into the left ventricle. Yes. Why? See, because of increase of something known as filling pressure. How? I'll tell you. See, imagine this is an LV. If it is not contracting properly, there is blood left into the LV even after the end of systole. Now, the blood has to come into the LV from LA during the diastole. Yes, if already some amount of blood is present, so it becomes difficult for the new blood to come in the next cycle. Yes, so what is happening is it is becoming difficult for this to fill. So the pressure that is required to fill this ventricle is increasing. That is what is known as filling pressure. So there is increase in filling pressure. Yes, how will you know what is filling pressure? See, it is basically easy. Filling is happening during and filling is happening during diastole. So filling pressure is equal to diastolic pressure. So we take the LVEDP. What is the meaning of this? LVEDP means left ventricular end diastolic pressure. That is equal to filling pressure. So If there is diastolic dysfunction of LV, it is increasing the filling pressure. What is the filling pressure equal to? It is equal to the left ventricular and diastolic pressure. Now, according to the physiology, during the end of diastole, LV pressure is equal to LA pressure, and LA pressure is equal to pulmonary capillary wedge pressure. So the pressure in the pulmonary capillaries are equal to LA pressure, and the LA pressure is also equal to LV end diastolic pressure. So try to understand this. LVDP is equal to LAP is equal to pulmonary capillary wedge pressure. So all of these pressures are somewhere around 10 mm Hg. Now I told you in diastolic dysfunction, there is increase in filling pressure. So it is increasing the pressure of LVEDP. If pressure in LVEDP is increased, it will increase the pressure in LAP and it will also increase the pressure in PCWP. Understand? So this is what is happening with the pressures. So what is happening? There is increase in LVDP that is causing increase in LAP that is causing increase in pulmonary capillary wedge pressure. Now, if the pressure in the pulmonary capillaries increase, yes, it becomes difficult for the blood to come into pulmonary capillaries. So where are the pulmonary veins receiving the blood from? It is receiving oxygenated blood from lungs. So if the pressure increases, what will happen? The blood cannot be received by pulmonary veins and blood will be flowing back. Understood? So the pressure in the pulmonary veins is increasing. Whenever the pressure in the veins increases, so it will increase something known as hydrostatic pressure. If the hydrostatic pressure is increased, the fluid is pushed away from the capillaries. So accumulation of fluid outside the capillaries in the interstitial space is known as edema. Understood? So increased pulmonary capillary pressure is also known as, it can cause acute pulmonary edema, or if it is not severe enough, it can cause nocturnal cough, or it can cause dyspnea or orthopnea or paroxysmal nocturnal dyspnea. Don't worry, I'll explain all of this to you in a minute. Basically, all of this is happening because the fluid is not able to come into, the blood is not able to come into left ventricle. So it is pooling back into left atrium. So it is pooling back into pulmonary veins. So this fluid is going from the pulmonary veins into pulmonary capillaries and from pulmonary capillaries into the interstitial cells or interstitium of the lungs. That is what is known as acute pulmonary edema. Yes, because of the fluid in lungs, it can cause nocturnal cough, it can cause dyspnea, it can cause orthopnea and also paroxysmal nocturnal dyspnea. Yes, so two things that we have studied. First, we started from left ventricle. There is a systolic failure, it caused forward symptoms. Yes, now any chamber that doesn't contract properly will also not relax adequately. So it is also causing acute pulmonary edema, nocturnal cough, dyspnea, orthopnea, PND. All of these are happening because of increase in LVDP symptoms. So these symptoms are seen due to increase in LVEDP. All of these are happening because of congestion in pulmonary veins. Yes, so we can also call this as pulmonary congestion. Pulmonary congestion symptoms. So easy way to remember this, LV systolic failure will cause forward symptoms LV diastolic failure will cause LVEDP symptoms or pulmonary congestion symptoms. So LV systolic and diastolic failure part is done. Now the next most important thing, see, imagine if the blood is being pulled back into the lungs. Yes, after this, the blood will start pooling into pulmonary artery also. It increases the pressure in pulmonary artery, thereby increasing the pressure in RV. So if filling pressure in RV increases, what will happen? There is increase RVEDP. I told you filling pressure in LV is LVEDP. So filling pressure in RV will be RVEDP. So it is causing an increase in RVEDP. Yes. What will happen when RVDP is increased? It is causing diastolic failure of LV. Sorry, diastolic failure of RV. So here, right ventricular failure is caused due to left ventricular failure. This is what happens in most of the people. That is why we started with LV failure. So the answer to the question, what is the most common cause of right heart failure? It is always left heart failure. Left heart failure itself is causing the right heart failure. Yes. Now, next, most common cause of isolated right heart failure. What is the most common cause of isolated right heart failure? Think about it. I'm waiting for your answers. What is the most common cause of isolated right heart failure? Think about it. It is pulmonary artery hypertension. So, if the blood pressure of pulmonary artery is increased, same, I told you, the filling pressure in the RV will increase and it is causing increase RVEDP. So, the second question, most common cause of isolated right heart failure is pulmonary artery hypertension. Now, this is the most important question. Try to answer this. Heart failure cells are seen in which organ? Heart, liver, lungs, or spleen? Which one? Try to comment. Most of the students have answered it as heart in the exams, but that is not true. See, heart failure cells are present in the lungs. Yes, this is a pathological question. Try to understand how this is happening. That is why I'm telling you all of this pathophysiology. How is this happening? See, I told you in LV systolic failure, the blood is filling back into the left ventricle. Good Chetra, good Shabuddin. Yes, it is lungs. KK, it is lungs. Yes, good. All of you good. So what is basically happening? The blood is being pulled back. So it has increased LVEDP, increased LAP, and increased PCWP. So there is blood that is seen in the interstitium and alveoli of the lungs. So when blood is present, what will happen? The macrophages will come and will engulf this blood. Yes, blood cells are made up of hemosiderin. So these are also known as what? These are also known as hemosiderin macrophages. Hemosiderin laden macrophages. So where are these are also known as heart failure cells. Now where are these seen? These are seen in the lungs. So that is the question. Heart failure cells are seen in lungs. Yes. What do you see in liver and spleen due to heart failure? Now I'll tell you. I told you there is increased RVEDP. So it is becoming difficult for the blood to come into RV from RA. So it is the blood is there in the right atrium, as you can see here. If the blood is being pulled back into right atrium, where will the blood go? The blood will go into inferior vena cava and superior vena cava. As you know, superior vena cava will drain the deoxygenated blood from superior part of the body. Inferior vena cava will drain the blood from the inferior parts of the body. Yes. Now, imagine if the blood is pooling back into SVC. So what will happen? the fluid will come out into the tissues that are present in the superior part of the body. Which tissues? First, it will start with periorbital edema. Why? Around the orbit, the skin is very thin, so it always starts with periorbital edema. And SVC is directly connected with right IJV. Yes, if the blood in the SVC increases, so the blood going into the IJV also increases, and this thing can be seen by the doctor. That is what is known as JVP, jugular venous pressure. So in this person, there is increase in JVP. Yes, so because of increased SVC, there is periorbital edema. So this is a symptom, and increased JVP is a sign. Along with periorbital edema, you also get facial edema. That is due to congestion in SVC. Now we will see congestion in IVC. Yes, IVC is draining the blood from lower parts of the body. So what are they? They are draining blood from abdomen. So if the blood is being pulled back into the abdomen, it will cause what? In the abdomen, it will cause ascites. Yes. If the blood is being pulled back into the liver, what will it cause? Congestive hepatomegaly. If the blood is being pulled back into spleen, what will it cause? Congestive splenomegaly. And if the blood is being pulled back into the limbs, what will it cause? It will cause upper limb and lower limb edema. And when you palpate this edema, it will pit, so it is known as pitting edema. So all of these are seen when the person is having a left ventricular failure. Now, the answer to this question. Heart failure cells are present in lungs. That is good. Now, in the liver, what do you see? It is known as congestive hepatomegaly. And it looks like nutmeg, so they also called it nutmeg liver. Yes. So in spleen, you see congestive splenomegaly. That's what happens to all the organs because the heart is failing. Now, let's try to revise it very fastly and then we will go to the next part. In the symptoms, I've told you. See, all the veins will carry deoxygenated blood except for pulmonary veins. So all the veins are being drained into SVC and IVC. So SVC and IVC are taking deoxygenated blood from almost all parts of our body and it is giving it to right atrium. From right atrium, it is going into right ventricle. From there, pulmonary artery is pumping this deoxygenated blood into lungs for oxygenation. Oxygenation happens in lungs. So oxygenated blood is taken by the pulmonary veins and it drains the oxygenated blood into left atrium. That is why left side we have oxygenated blood, right side we have deoxygenated blood. From left atrium, the oxygenated blood is going into left ventricle. Now, the left ventricle will pump during the systole to pump the oxygenated blood to all parts of our body. Yes, so this is what is happening during systole. Now, what I'm telling you is there is an LV failure. So there is first systolic failure. It is not pumping blood to all parts of our body. If our body is not getting oxygenated blood, first we'll be tired. That is what is known as fatigue. And if there is no blood supply to the brain, it will cause altered mentation. If there is decreased blood supply to the kidney, it will cause oliguria. Because decreased cardiac output, there is decreased blood pressure. It can cause pallor. It can cause cool extremities. And as I've told, because of increased blood in the left ventricle, it can cause a sound that is known as S3. S3 is not usually heard except in extraordinary conditions like young people and athletes. In adults, S3 is not usually heard except for pregnancies. But if you're hearing an S3 in here, so that is a pathological sound. And also you will feel pulses alternance. So LV failure will cause forward symptoms because the blood is not pumping forward. Next, what I've told you is any chamber that doesn't contract properly will not relax adequately. So because there is LV systolic failure, this LV systolic failure will cause LV diastolic failure. Now, because of LV diastolic failure, there is increase in filling pressure. That filling pressure is equal to increased LV-EDP. Now, LV-EDP is equal to LAP is equal to PCWP. So, if LV-EDP is increased, PCWP is increased, and the blood amount in the pulmonary capillaries will increase. So, the fluid moves out from capillaries into the interstitium or alveoli, causing the pulmonary edema. And all of these symptoms can be seen. So these are increased LVEDP symptoms. Now, I told you the diastolic failure of LV will cause the diastolic failure of RV. So most common cause of right heart failure is obviously left heart failure. So it increases RVDP. RVDP will cause periorbital edema, increased JVP, facial edema, ascites, congestive hepatomegaly, congestive splenomegaly, and upper limb and lower limb edema. So this is what is happening. So all of this is, you're seeing edema everywhere. You can also call it as generalized edema. You can also call it as generalized edema. And did you understand till here the symptoms and signs? Do comment and let me know, and we will see the next questions whether you understood this topic or not. The questions is, first is, which is not included in the Framingham's criteria of heart failure. Next, which is the sign of impending right heart failure. We'll see what these are. Good Shabuddin and good Chatra. So Framingham's criteria. See, Framingham's criteria is for the diagnosis of heart failure that is based on the symptoms. What the Framingham told us is you need either two major criteria or one major plus two minor criteria. Yes. If we study the symptoms like this directly, it becomes little difficult for us to remember all the symptoms. That is why we've done the pathophysiology and we've seen the symptoms. Now we'll try to understand each and every symptom. Yes. Now, first, in major, we have something known as acute pulmonary edema. Now, you guys comment and tell me, why do you see acute pulmonary edema? Is it a forward symptom? Is it because of increased LVDP or is it because of increased RVDP? Comment and let me know. Good Kshetra, you get acute pulmonary edema because of increased LVEDP. Next, hepatojugular reflex. I'll talk about this. Next, neck vein distension means increased JVP. How do you get increased JVP? It is because of increased RVEDP. Now, how do you get PND or orthopnea? You get it because of increased LVEDP. Yes. Now, why do you get cardiomegaly? You get cardiomegaly because of forward symptoms. Forward symptoms meaning there is decreased cardiac output. So more amount of blood is being retained in the left ventricle, that is increasing the volume of left ventricle. Yes. So it is causing cardiomegaly. So it is a forward symptom or forward sign. Next, rails. Yes, good Chatra, hepatojugular reflex is due to increased RVDP. Rails, what is the meaning of rails? It is crepitations. Whenever there is fluid in the lungs, there are crepitations. So why do you get creps in lungs? Due to fluid. Why do you get fluid? Because of increased LVEDP. Next, third heart sound. How did you get third heart sound? I told you because of increased LVEDP, you got third heart sound. And also because of forward symptoms, you got third heart sound. S3 can be caused, S3 can be heard in both systolic and diastolic failure. So it is due to increased LVDP, and also it is a forward symptom that is because of decreased cardiac output. So these are the major criteria, and now we'll see the minor criteria. Dyspnea. How do you get dyspnea? As I've told, it is increased LVEDP. Nocturnal cough, it is increased LVEDP. How do you get edema? Because of right heart failure, so it is because of increased RVEDP. Hepatomegaly, I told you, congestive hepatomegaly and nutmeg liver. So it is due to increased RVEDP. Pleural effusion. What is the meaning of pleural effusion? Effusion in the pleural spaces. This is happening because of generalized congestion. Next, tachycardia. How is it? How is tachycardia seen? Because of forward symptoms. Because of systolic failure, there is decreased cardiac output and it will increase the heart rate. That is what is known as reflex tachycardia. So if you study it this way, it makes sense. Yes, if you study the pathophysiology of it, all of the Framingham criteria make sense. You can understand how do you get the Framingham's criteria. So these are major and minor criteria. So if you see two major criteria, you can say it is heart failure. Yes, if you see one major plus two minor criteria, you can also say it is heart failure. So this is about Framingham's criteria and all the symptoms that we've seen. So now we'll come to the questions. Which is not included in the Framingham's criteria of heart failure? Is it hepatomegaly, S3, JVP or angina? Hepatomegaly we studied. I told you it is because of increased RVDP. It is present in Framingham's criteria. S3 I told you it is because of decreased cardiac output and also increased LVDP. So it is also a part of Framingham's criteria. JVP also we studied. JVP we are getting because of increased RVDP. So the answer is angina. Good, Shabuddin. Angina is the answer. It is not included in Framingham's criteria of heart failure. What is the sign of impending right heart failure? This is the most important thing. Yes. What is the sign of impending right heart failure? Increased JVP means already there is increased RVDP. So this basically means there is right heart failure. Hepatomegaly means increased RVDP. So basically this means right heart failure. Ascites also means right heart failure. But the question is impending right heart failure means if you check for this, you will say that right heart failure is pending. You don't know the patient is having right heart failure, but you want to guess whether he will go into right heart failure or not. So what will you check? You should check for something known as hepatojugular reflex. What is the meaning of this? See, this name is a misnomer. Why? Hepatojugular reflex meaning we should be pressing the patient's umbilical area, not the hepatic area. So people thought we should be pressing the hepatic area. That is not true. You should apply pressure on the umbilical area. So it is better if we call it as abdominojugular reflex because we are pressing on abdominal area on the umbilical region. So if we press on the umbilical region, it will increase the blood flow into the thorax. So it is supposed to be increasing the JVP a little. It should increase the JVP by 1 millimeter. But in patient with impending right heart failure, this JVP will be increased by 3 millimeters for more than 15 seconds. Then you can say hepatojugular reflex or abdominojugular reflex is positive. If this happens in the patient, that means the patient is about to go into right heart failure. That is the meaning of hepatojugular reflex. It is a sign of impending right heart failure. Please try to remember this. Imagine you seen a patient with left heart failure. He is having dyspnea, orthopnea, and paroxysmal nocturnal dyspnea. Now you want to see whether he will go into right heart failure or not. What can you do? You can check for abdominojugular reflex. If it becomes positive, then the patient will go into right heart failure soon. That is the meaning of this. Which is the sign of impending right heart failure? It is hepatojugular reflex. Please try to remember this. This is an important question. Did you guys understand? Comment and let me know. Next, after the symptoms, We will see some miscellaneous topics. Meaning of miscellaneous topics, that means it is not really related to heart failure, but you need to know all of this while studying the cardiology. First, first thing is first rank symptoms of cardiology. First rank symptoms of cardiology means the most important symptoms in all the disorders of cardiology. What are they? One is angina. What is the meaning of angina? Chest pain due to any cardiac cause. Yes, that is what is angina. Next, what is syncope? Syncope means a transient loss of consciousness that is followed by recovery. Next, what is dyspnea? I told you we'll talk about dyspnea and why. So, we'll be talking about dyspnea now. What is the meaning of dyspnea? See, usually we are unaware of our own breath. Breathing is involuntary. It is being done by the what? Centers, respiratory centers in pons and medulla. Yes. So, if we become aware of your own breath, it is unpleasant awareness of one's own breath. That is what is known as dyspnea. Unpleasant awareness of one's own breath. That is what is known as dyspnea. Yes, if you get dyspnea in supine position, that is what is known as orthopnea. Dyspnea in supine position is known as orthopnea. Next, we are left with one more thing, that is paroxysmal nocturnal dyspnea. What is the meaning of this? It is given in the name. There is dyspnea during the night. Paroxysmal means in the form of an attack. Imagine a person is sleeping, he is having sudden dyspnea, that is shortness of breath or unpleasant awareness of one's own breath. Yes, if he is having dyspnea suddenly in the night in the form of an attack, that is what is known as paroxysmal nocturnal dyspnea. What will the patient do? The patient will wake up, he'll walk and he'll take a deep breath and he'll come back and sleep. That is what is known as paroxysmal nocturnal dyspnea. Next, palpitation. What is the meaning of palpitation? It is the same. We are unaware of our heartbeat. Yes, heart is beating inside of our body, but we don't know how many times it is beating and we don't feel it also. If you are able to feel it, that is what is known as palpitation. It is awareness of one's own heartbeat. Good, Chetra. Yes, it is unpleasant awareness of one's own heartbeat. So these are the first rank symptoms of cardiology. Even though they are first rank symptoms of cardiology, in Framingham criteria, angina, syncope, and palpitations are not included. It doesn't mean heart failure patient will not have these. They will be having sometimes angina. They might even have palpitations. Yes, dyspnea, anyways, it is included in Framingham criteria. So these are the important symptoms that you see in cardiology. Why I'm telling you this? Because of this classification, NYHA classification. If you see a person with dyspnea, yes, you cannot say it is mild dyspnea or severe dyspnea. That is not the way to describe it. You have to describe it with the help of NYHA classification. What does the classification say? Usually there are 4 classes. Yes, class 1, class 2, class 3, and class 4. Class 4 is the most severe classification. What is the meaning of this? The patient is having severe symptoms in class 4. So we'll start from class 4. Patient will have symptoms even at rest. That is what is known as class 4. Yes, so class 4 is the most severe form. Yes, next. Next is class 3. Patient will have symptoms at less than ordinary activity. See, if the patient is doing even an activity that is less than the normal activity, he will be having symptoms then. That is class 3. What is less than ordinary activity? What is ordinary activity? Walking, running, climbing stairs, it is ordinary activity. Less than ordinary activity, waking up, keeping on his clothes, brushing, combing, Yes, eating food, all of these are less than ordinary activities. If he is having symptoms while combing his hair, while dressing up, yes, while bending, all of these. So if he is having symptoms less than ordinary activity, that is what is known as class 3. Now, if the patient has symptoms, if patient has symptoms at ordinary activity, that is what is known as class 2. Now, what is class 1? The patient will not have symptoms at rest, no symptoms at rest, no symptoms in ordinary activity. The patient will have symptoms only on exertion. So that is class 1. So class 1 is the mildest form, class 4 is the severe form. So now, where can you use this NYHA classification? NYHA classification is for all the first rank symptoms of cardiology except for syncope. So except syncope meaning angina. What else is there? Palpitation and dyspnea. If the patient is having dyspnea at rest, that is what is known as class 4 dyspnea. If the patient has dyspnea on exertion, that is what is known as class 1 dyspnea. Same. Angina at rest, class 4 angina. Palpitations at rest, class 4 palpitations. Did you understand the NYHA classification? Do let me know and we'll go to the next slide. These are the miscellaneous things you need to know. First rank symptoms of cardiology and NYHA classification. And finally, it is staging of heart failure. Yes. See, Tosade Depointis is not related to this topic. We'll talk about it when we are doing that lecture. Yes, it takes very long to explain the entire Tosade Depointis. Yes. So next is staging of heart failure. Now, there are 4 stages again, stage A, B, C, and D. Stage A meaning the patient doesn't have a structural disease. The patient is asymptomatic. That means no symptoms of heart failure. He is only having risk factors. Risk factors of heart failure. Imagine he is having hypertension, diabetes, some risk factors like this, metabolic syndrome, any of the risk factors. Then you can call it as stage A. Basically, he is not having heart failure yet. He has only the risk factors of heart failure. That is what is known as stage A. Now imagine stage B. What is it? The person is still asymptomatic. That means he's not having heart failure yet, but he's having some structural heart disease. Example of structural heart disease usually is LVH. Now, stage C. The person has structural heart disease along with symptoms of heart failure. This is the heart failure that we are studying. So that is stage C. So if you see a patient with symptoms of heart failure, you can call it as stage C heart failure. Stage D is refractory heart failure. I'll tell you which drugs to use for heart failure. Even after using all the drugs, if EF is less than 35%, if the EF is not improving even after using all the drugs, that is what is known as stage D. Yes. So these are the stagings of heart failure. This is NYHA classification, and we finished the first rank symptoms of cardiology. Now we'll start with the treatment portion. If you remember the pathophysiology, the treatment becomes fairly simple. Why? Why is heart failure happening? Comment. Heart failure happens because of compensatory mechanisms. What are the compensatory mechanisms? Renin-angiotensin-aldosterone system activation and sympathetic nervous system activation and inhibition of natriuretic peptides. Yes, and activation of ADH. So these are the 4 things. So if we block all of this, we are treating heart failure. So we block renin-angiotensin-aldosterone system with the help of ACE inhibitors or ARB. We are blocking sympathetic nervous system with the help of beta blocker. Mineralocorticoid receptor is blocking the aldosterone in the renin-angiotensin-aldosterone system. This is the new group of drugs, that is SGLT2 inhibitors. Now we'll talk about all of these. See, I'm taking back to pathogenesis for you to understand why we talked about pathogenesis so much. Whenever there is decrease in cardiac output, the heart is trying to maintain it by increasing the sympathetic nervous system. Now, activating the sympathetic nervous system will release catecholamines and it will release the heart rate. Yes, now we want to block this. We can block it by the help of beta blockers. Yes. Now, second one is with the help of renin angiotensin aldosterone system, it is trying to increase the cardiac output. It does it by what? Vasoconstriction and increasing the preload. How is it happening? You can see here. Angiotensin 2 is activating on AT1 receptor causing vasoconstriction. It is acting on adrenal gland that will release aldosterone to cause sodium and water retention. Now we want to block this. So we are using what? ACE inhibitors or ARBs. I'll tell you there is one new drug that have come up instead of ACE and ARBs. Yes. Now we want to block the spironolactone, so we are using mineralocorticoid receptor antagonist. That is what is spironolactone. That is blocking the aldosterone. So these are the drugs that we are using for heart failure. We'll talk about it one by one. First, I told sympathetic nervous system overactivity is causing the heart failure. So you're blocking the sympathetic nervous system by using beta blocker. So first line drug is beta blocker. In beta blocker, according to the guidelines, 3 beta blockers are used for this. That is MBC. Means metoprolol, bisoprolol, and carvedilol. Now, most important point to know, beta blocker has got the highest mortality benefit in all the drugs. Highest mortality benefit. So it is a first line drug. So second, we want to block renin angiotensin aldosterone system. This is by ACE or ARBs. Now, which one is better? What do you think? I'll tell you which one is better by using this same diagram that we studied in pathogenesis. I told angiotensin 2 is activating the angiotensin 1 receptor and causing vasoconstriction. Yes, angiotensin 2 is activating the angiotensin 2 receptor to cause vasodilation. But this receptor activity is more, so we are getting vasoconstriction. So what does angiotensin receptor blocker do? It will block this receptor. So it will decrease vasoconstriction, but angiotensin 2 can still act on angiotensin 2. So it is causing vasodilation and natriuresis. That is one good thing. Now, with ACE inhibitor will directly block the ACE. So angiotensin 1 is not converted to angiotensin 2 itself. So it cannot act on AT1 and AT2 also. But problem with ACE inhibitors is ACE is similar to an enzyme that is known as kinase. So if you're blocking ACE, you're also blocking kinase. What does kinase do? It will convert the bradykinin into inactive metabolites. That is what kinase is doing. Now, if you're blocking kinase, there is increased bradykinin levels. So bradykinin is a potent vasodilator, and bradykinin activity is very important to us during heart failure. Why? Because bradykinin is causing vasodilation. So comparison with ARBs, ACE inhibitors are better in heart failure. But when you see in hypertension, it is the opposite. How is it opposite? In hypertension, ARBs are better than ACE inhibitors. Try to understand this. How? See, in hypertension, even though ACE inhibitors are blocking all of this, if you are using ARBs, we are just blocking this receptor. A2 is working fine and it is causing vasodilation. That is good for us. and bradykinin level also is decreased. Now, if bradykinin level is increased, it can cause something known as dry cough. Why? Bradykinin can activate the medullary cuff centers. So it can cause dry cough. That is one. Bradykinin is a potent vasodilator. At the same time, it is also causing increased capillary permeability. So fluid will move out, causing edema. That is also known as angioedema. So in hypertension, if you are using ACE inhibitors, the side effects are dry cough and angioedema. And it is also contraindicated in pregnancy. Yes, so ACE inhibitors are having lot of side effects in hypertension compared to ARB. ARB is not working on kinase, so bradykinin is reduced and it is only acting on AT1 receptor. So it is decreasing the vasoconstriction. AT2 receptor will cause the vasodilation and natriuresis, that is good for us. But in heart failure, even though we are getting these side effects, we need the effect of bradykinin to cause vasodilation. So even with side effects, ACE inhibitor is better than ARB in heart failure. Now we've got up with a new drug that is even better than ACE inhibitors. The name is ARNI. What is the meaning of ARNI? It is angiotensin receptor blocker plus neprilysin inhibitor. What is the meaning of neprilysin inhibitor? What does neprilysin do? Neprilysin will degrade something known as bradykinin, and it is degrading something known as ANP, atrial natriuretic peptide. If you remember, we studied this also. And it is also degrading angiotensin 2. Now, if we are inhibiting this neprilysin, what will happen? Bradykinin is increasing. That is good for us. That is what ACE inhibitor is doing. Yes. Next, it is also increasing the atrial natriuretic peptide. So if atrial natriuretic peptide is increased, it causes natriuresis. So it is good for us in heart failure. Now, it is increasing the angiotensin 2. Is angiotensin a good molecule or a bad molecule? Let me know, is angiotensin a good molecule or a bad molecule? See, we don't want angiotensin 2 because angiotensin 2 will cause vasoconstriction. So if we are inhibiting the neprilysin, we are getting good effects of bradykinin and ANP, but unfortunately AT2 is also increasing. Now we are combating this with the help of angiotensin receptor blocker. It is blocking this effect of angiotensin 2. So you can see how many good effects we are having this drug. Neprilysin inhibitor is causing increased bradykinin and increased ANP, and ARB is decreasing this angiotensin 2. So we are using angiotensin receptor blocker plus neprilysin inhibitor. What is it? It is valsartan plus sacubitril. So this has got the second highest mortality benefit. So first drug with highest mortality benefit is beta blocker. Second is ARNI. Third, it is spironolactone. So I am giving you in the order of mortality benefit. What is spironolactone doing? I've already told you the action of aldosterone in the last lecture. Aldosterone is coming into the capillary. It is crossing the basolateral membrane and attaching to the mineralocorticoid receptor. So spironolactone is a mineralocorticoid receptor antagonist. So if spironolactone is blocking the mineralocorticoid receptor, aldosterone cannot act with it and it is decreasing all the things that aldosterone is doing. So it is causing natriuresis, that is good for our body. So this has got the third highest mortality benefit. Now last and final is SGLT2 inhibitor. Now how is this useful? Let me know, SGLT2 inhibitor, have you heard about it? What is this? This is nephron, and in nephron you have PCT. After nephron, there is glomerulus. These are parts of nephron. This is glomerulus, and you have PCT. So whenever there is blood going into the arterioles, which arterioles are there? Efferent arteriole, efferent arteriole. Yes, do you remember this efferent and efferent arterioles at least? So these arterioles are forming the glomerular capillaries. So when the blood is coming here, it will be filtered. It will be filtered in, and it is released into the Bowman space. And this is how it is coming into the urine. Yes, PCT, loop of Henle, DCT, and finally collecting ducts. Now, what will happen when the blood is being released here? When the blood is being secreted here, what will happen is glucose will be reabsorbed from the PCT. How much glucose? 100% of glucose will be reabsorbed in the PCT with the help of SGLT2. With the help of SGLT2. Now, hello Buzz, hello. Peculiar username. Yes. So it is reabsorbing the 100% of glucose through PCT. Now, if we are blocking this SGLT2 channel, all of the glucose, yes, all of the glucose will be lost in the urine. Understood? So this is a diabetic drug. It is a diabetic drug. See, you can see in the name that it is SGLT2. SGLT2 meaning sodium glucose linked transporter. The glucose is not being reabsorbed and the sodium is also not being reabsorbed. So the sodium is also coming out in the urine. Wherever sodium follows, water will follow. So it is causing natriuresis. That is what is important to us. It is a diabetic drug, but has found to be a very effective drug in the heart failure. Yes, it has got cardiac protectivity. Understood? So this is about the SGLT2 inhibitors. Example is canagliflozin and dapagliflozin. So these are the drugs you should be using. Beta blocker, RAS inhibitors, spironolactone, and SGLT2. So how to use it? That is what we have to study in medicine. So this is basically pharmacology. 4 drugs are useful, but which drugs to use them in medicine? How to use them? In which order to use them? That is what is important. Why? See, the patient is having heart failure, meaning the patient is not able to pump out the blood properly. Whatever pumping is happening, it is happening because of the compensatory mechanisms. When sympathetic nervous system is activated, his heart rate is increased. Now, if we are giving a beta blocker directly, yes, the patient has volume overload. Do you remember the patient has volume overload because of pulmonary congestion and systemic congestion because there is increased LVDP and there is increased RVDP. Now, if we directly give beta blocker, it will reduce the heart rate. Whatever cardiac output we are getting will be lost. Yes, some of it will be lost. Now, more fluid will accumulate in the lungs and it will cause pulmonary edema. So, we should never give beta blocker directly when there is congestion. How can you know if the patient has having congestion or not? What do? You can check for IVC diameter. If the IVC diameter is more, that means the patient is congested. Congested meaning there is lot of volume overload. When a patient has volume overload, what should you do? You should be giving diuretic, obviously. Diuretic will cause loss of fluid from the body, diuresis. So which diuretic should be used? It is torsemide. So we can use torsemide 5 mg. You can give it 2 times a day and you can start him on Arni along with torsemide. because we are not able to use beta blocker because there is volume overload. Now, you give this for 7 days and look at the IVC diameter. If the IVC diameter becomes normal, that means the patient is euvolemic. The volume congestion has decreased, volume overload has decreased. Once the volume overload is decreased, you can give beta blocker. Then you can add him on spironolactone. And finally, you add him on what? What else is left? SGLT2 inhibitor. So this is the treatment. Never give beta blocker directly if there is volume overload. What you should do, you should correct the volume overload by giving what? Diuretic. So start with diuretic and ARNI. Once the patient becomes euvolemic, you can add him on beta blocker. Finally, you can give spironolactone and SGLT2. So this is about chronic heart failure. Yes. So you waited this long, wait for 5 more minutes. And in these 5 minutes, we'll try to revise all the 5 concepts in chronic heart failure. What are the five concepts? First is definition. Yes, definition, what I've told you, it is a complex clinical syndrome due to a structural or functional abnormality that is causing impairment in filling or pumping. So this is what is known as heart failure, complex clinical syndrome due to a structural or a functional abnormality that is causing the impairment of ability of ventricle to fill itself or eject out blood. That is heart failure. Now classification of heart failure is based on EF. So that is HF, REF, HF, MEF and HF, PEF. Now we've only studied REF because that's all we know about till now in the guidelines. Now, how did HFrEF happen? It happened because of compensatory mechanisms. Imagine if there is any index event. Example, there is MI that is causing a loss of function of the LV. So it will cause decreased cardiac output. Now we want to increase the cardiac output by compensating. What are the compensatory mechanisms? I told you first is sympathetic nervous system activation that will cause renin angiotensin aldosterone system overactivity, and this will cause release of ADH hormone, and finally there is also inhibition of natriuretic peptides. Yes, so 3 concepts done. Next are symptoms. What are the symptoms? When there is LV systolic failure, what can you see? There is decreased cardiac output and it is causing forward symptoms. We've studied what are the forward symptoms. What are those? Tell me. It is fatigue, oliguria, altered mentation, cool extremities, pallor, S3, pulsus alternans. Yes. And any chamber that doesn't contract properly will not relax properly. So LV systolic failure will cause LV diastolic failure. If there is LV diastolic failure, it will increase the filling pressure. What is the meaning of filling pressure? It is LVEDP. LVEDP is equal to LAP, it is equal to PCWP. So if LVEDP is increased, it will cause increase in LAP and increased PCWP. That is what is causing acute pulmonary edema, and it is causing nocturnal cough, dyspnea, orthopnea, paroxysmal nocturnal dyspnea. Yes. Now, LV diastolic failure will in turn cause RV failure. So this will increase the filling pressure of RV. So it is increasing the RVEDP. If RVEDP is increased, it will cause periorbital edema. Yes, increased JVP, facial edema, ascites, hepatomegaly, splenomegaly, and edema all over the body. So these are the symptoms of heart failure in progression. First, you had seen LV systolic failure that is causing LV diastolic failure. LV diastolic failure is causing RV failure. So most common cause of RV failure is left heart failure itself. Now, after the symptoms are done, treatment. I told you, you block all these systems. You block the sympathetic nervous system with beta blocker. You block the renin-angiotensin-aldosterone system with ARNI and spironolactone. If you are blocking renin-angiotensin-aldosterone system, ADH will also be decreased. Yes, you're increasing the natriuretic peptide again by ARNI. Yes, neprilysin inhibitor is increasing the atrial natriuretic peptide. And the latest drug that we are using now is SGLT2 inhibitor. So basically, this is heart failure in a nutshell. In 5 minutes. Yes, definition, classification, compensatory mechanisms, symptoms, and treatment. So if you know these 2 slides, you know everything about chronic heart failure. Yes. So this is about chronic heart failure. If you have any doubts, you can post it. I'll wait for 1 minute and then we can end the stream. Okay, thank you guys. So we'll end the stream here. Thank you all of you for participating. So have a nice weekend. If you have any doubts later on, you can post it in the comments. Yes. Thank you, Chatra.